Okay, so we are on Facebook. We are on, just checking if we are on YouTube. Yeah, we are on YouTube as well. I'm just checking whether we reached LinkedIn as well. Okay. So let me start by starting the slideshow. Good evening, everyone. Thank you for joining us today. We are here, this month is Rheumatic Disease Awareness Month. So we are back this year again with a discussion around impact of rheumatic diseases on women. Specifically, that's the focus this time. Just quickly do a round of introduction. As some of you would already be aware, Patients Engage is an online platform and it seeks to inform, engage, empower patients and caregivers. We strongly believe in lived experiences of people and the fact that patients' voices should be center stage in healthcare. Let me introduce our panelists today. We have, and this is in alphabetical order, the same format as our poster. We have Prachee Bhosle, who's the president of Ankylosing Spondylitis Welfare Society based out of Pune. We have Dr. Latika Gupta. She's the assistant professor, clinical immunology and rheumatology at SGPGI, Lucknow. Kirtida Oza, the co-founder director of Sjogren's India, focused on Sjogren's syndrome, and we'll have Dr. Sapan Pandya, who will join us soon. He's the consultant clinical immunologist and rheumatologist from Ahmedabad, as well as he's the secretary of the IRA, the Indian Rheumatology Society. And we have Neetu Wadhwa, who's the founder of Scleroderma India. And I'm Aparna Mittal. I'm the moderator for the session, and I'm the CEO of Patients Engage. As always, our guidance to our attendees is that this is not replacing a medical consultation. It's information to be used in your discussions with doctors, but it does not, you do not take it as medical advice. This session is being recorded, and if you're logged into Zoom, you can post your questions on the Q&A. If you're on Facebook, YouTube, or LinkedIn, you can post the questions, comments on the live feed. And as always, you can share or write into us at editor@patientsengage.com, and you can follow us on our social media pages on Facebook, Twitter, YouTube, LinkedIn now, and Instagram. Also, we wanted to let you know that in case you need to reach to these patient groups, some of the patient groups for rheumatic diseases, we've got Sjogren's India. The number is 8200749302. These are, I think, WhatsApp numbers. Scleroderma India as well, Ankylosing Spondylitis Welfare Society. The contact is Bhushan Gate. There's also another one that we had worked with last year, Antardhwani, based out of Gujarat. We've got Lupus Trust India, and Myositis India is a Facebook group which is also available. There are a few more, but for now, that's what we have captured. So let me get started because we have a lot of points to discuss, and we have Prachee twice. Prachee.
Yeah. I just
Okay, so I'll add that Dr. Latika in the notes for the webinar, the Myositis India number. So as I said, women do get affected more by rheumatic diseases. And one of the things I would like to highlight is that our patient leader panelists represent not just their experiences, but the experience of the community of patients that they have interacted and supported and researched over the last few years. So let's start with you, Dr. Latika. If you can just tell us briefly what are rheumatic diseases. I think, Doctor, you are on mute.
So, very warm good evening to all, and firstly, thanks so much, Aparna, for having me on board. It's really an honor to join here today. And rheumatic disorders basically mostly are referred to, are used to refer to any kind of rheumatism, that is, disorders which involve the joints. And classically, rheumatoid arthritis was thought to be the prototypic rheumatic illness. But over time and over the years, our understanding has greatly expanded. Some of our patient leaders would also agree with various disorders, mostly of autoimmune origin, which involve different organ systems. They can affect the skin, they can affect the joints, the muscles, they can involve the lungs. So, as we all know, most of the rheumatic disorders, unfortunately, are more common in women, which is in line with the theme of today's webinar, making it very important to understand the complex issues underlying these. For some disorders, the situation is worse, that like women may be affected up to 9 times more often than men, like
Wow.
for Sjogren's, while for some disorders like uh, rheumatoid, the ratios may not be that bad. And for spondyloarthritis, that is the only group which is more common in men.
Right.
But there, women can bear the brunt of it because often it goes undiagnosed in women just because it is rare in them.
Correct. Correct. And, in what are the different ways in which rheumatic diseases affect women?
So I think this question, it's a very deep question, I would say, because the ways in which the entire dynamic of being a woman and having a rheumatic illness, the way it engages with the person's life, in line with our discussion before the webinar started, that diseases don't affect a person, they affect families.
Correct.
And it affects the person, and there's a disease person dynamic, and then there's a societal layer added to it. So I feel like rheumatic illnesses per se, it is widely known that they affect mobility. So most of these patients, they would have problems with pain and physical function, which will impair their ability to work. And in a progressive society, as we are all the countries, they're moving more towards, civilization is moving towards the developed world. Women are expected to be, there's this era of gender equity. So women have to work, they have to carry on household activities, they have to bear children. So it affects the ability to work. And professional front, home front, there's a lot of fatigue which goes unsaid, and it's often poorly understood. And I'm sure our patient leaders can vouch for that. These patients often suffer from severe fatigue, which may manifest early on in the day. And, it is something which is very poorly understood even by doctors at times.
Correct.
And there will be no temperature, there will be no physical sign, it's not measurable. The only way it can be measured is how the patient is feeling. And then to add it to that is the pain of not being understood sometimes. So that is like the physical aspect of it, I feel. Of course, in disorders like systemic sclerosis and other connective tissue disorders, it can be even more layered with different organ systems, depending on what involvement the patient has. Like if their lungs are involved, then they would get breathless on walking even a simple flight of stairs. And
Right.
if your skin is involved, some disorders in the peak stage, like systemic sclerosis, you feel like you're hide bound, that mobility is impaired, or your fingers are like tight and it's not like normal, and sometimes the skin is shiny, so it grabs more attention than required. So these are other things. And then of course there is the societal dynamic and social ostracization, poor awareness. People would come and ask that doctor, do you think I'll transmit this to my children? Do you think this is communicable? And oftentimes the societal stigma is such because of, I think, largely fear of the unknown, that people end up concealing that they have this illness. In India, where I practice, I sometimes see that it may be very difficult for people who are of childbearing age and marriageable age to even find a suitable match. Some of them are forced by families to conceal their illness, or if they are married and concealing, we would need to switch them to drugs which would not require, daily pill consumption. And then there is this dynamic of medicines interacting with the risk of affecting the fetus. So, and of course, if there are accidental pregnancies, they are another story altogether. So I think these are just some aspects of it, but there is a lot more that goes on behind the scenes. And hopefully we can move ahead with time with greater awareness on this front.
Right. Thank you, Dr. Latika. I think you kind of covered pretty much most of the issues that women face, and it kind of, forms a good introduction to the rest of the segments. I think and as you said, given the structural framework of our society, call it patriarchal or not, women face all kinds of issues, as you talked about. And it's, as you said, it affects not just physiologically, it affects body image, it affects their social interactions within the family, outside the family. And there's constant pressure to whether to disclose or not to disclose, and whether they get acknowledged, even the issues, and compound that with the lack of awareness, lack of access. I think it really complicates matters. But let's start with each of our patient leaders. So let's talk about the visible effects of rheumatic diseases first and how they affect body image. So if each of you can talk about how the condition affects, the condition that you represent affects people, that would be great. So Neetu, if you could start with how scleroderma affects people who have that condition. You're on mute.
So looks are an important criteria, or rather first criteria, by which society or people around us judge. So with scleroderma in the picture, the visible changes which I have felt and the other warriors face are, there is a skin color which gets darker, the pigmentation and depigmentation patches, that is white and black patches, appear on face and on various parts of body. Then your skin gets dry and patchy. Then you have telangiectasia, that is red marks on face and different body parts. Then there is finger swelling, and gradually fingers get curved, something like this actually. Okay. And then there are ulcers on finger knuckles, which are very difficult to go away. And then there are changes around the mouth. A lot of us have mouse-like appearance because our tooth structure has changed. Our teeth, they have gone into different places now. Our lips have shrunk, and there is a lot of hair fall also. And the skin has become dry. The hair has become dry. So like me, most of the patients have gone through the depressive phases in their life, where they have lost confidence and they have lost self-worth, and they had a lot of self-worth issues also. In the initial years, it was really tough for even me to accept these changes and come to terms with the disease. More so because there were no support groups that time, where we could have actually gone through and talked to anyone. And the biggest mistake which most of us did, and in fact, a lot of patients even today do, is they don't talk about these issues with their doctors. So with doctors, we feel we just need to go there, take the medicine and come back. I'll just cite a small example of a beautiful, intelligent, highly educated girl in our support group who went for lip fillers to enhance her lips as she had lost all confidence. But
Right.
eventually, even lip fillers have their life. So they came out after 1.5, 2 years. So now we counsel patients to feel comfortable in their skin and not to spend money on dermatological or cosmetic treatments as they are short lived.
Right.
Our focus should be control the disease progression so that it should not affect internal organs. Because in scleroderma, as even Dr. Latika also mentioned, it is important that scleroderma should not progress till that level where it affects our internal organs.
Right.
So that has been an important point where we counsel our patients and we tell them not to worry about looks too much. It's a difficult job, but yes, we keep doing it.
Yeah. No, I think it is. Thank you, Neetu, for bringing that up. And you're right that disease progression management is a factor, but I guess for a lot of people, symptom management is also an issue that will need to be addressed. Prachee, do you want to talk about how? Welcome, Dr. Sapan. Yeah, Prachee, would you like to talk about how ankylosing spondylitis affects women
Yes,
specifically?
absolutely. AS generally affects people differently in different ways, and it really varies depending upon how far is the disease in that person, when was he diagnosed, and what kind of ongoing treatment the person is receiving. Many usually tend to bend forwards from the neck like this because they've got a hunch because there's a neck fusion, or at times because the lower back is affected, they bend from the lower back, making it difficult to walk or even look straight. And and this is, I'm talking about the extreme unmanaged forms of AS.
Right.
Or many because they get hip joint fusion or there's a pain in the hip joint, they start limping. Many, in worst cases, they've got, as they say, a bamboo spine, which is like the fusion of the vertebrae. So it makes it impossible for them to even leave the bed because the whole back is kind of fixed. Now, in
Right.
my case, because of the diagnosis and the treatment, initially, if you look at me, AS is really an invisible disease in my case. So if you think, you will be like, oh, no, she's fine. She's like normal, so to say. There's no visible damage. But
Right.
the moment I start exerting, the moment I start walking more or doing something more, gradually my body starts to compensate by either limping or kind of going slow. And so you'll automatically see a visible change in my walking style. At
Right.
times, especially for women during their periods and stuff, the pain becomes more. So it's difficult to even walk or take your own pressure. So you need a walking stick. Many people need various aids, be it simple like neck collars or compression socks, or at extreme times wheelchairs to get around through their day. So, and plus, because we have meds going on, there is water retention, and the meds make us put on weight. So, we start, and because of the aches and pains, it becomes difficult to even lose that weight. So, we again, when people look at us, they don't see the illness, but they look at us and they say, no, she looks lazy. So, it kind of adds to that yes. So, we are struggling, but the struggle doesn't come across. We just come across as more lazy because we walk slow, we look fat, we come
Right.
across that way.
Right.
So
Right.
this kind of affects, yeah.
Thanks. Thanks, Prachi. Kirtida, I think Sjogren's is a whole different set of issues, right? So how, yeah, you'll need to unmute yourself.
Yeah. Hello, everyone. I represent Sjogren's India, and I am myself a Sjogren's syndrome patient. One of the foremost ways in which women are affected by Sjogren's syndrome is that 90% of Sjogren's patients are women. So this is one of those lesser known diseases where women are predominantly affected. Besides the things that Prachee and Neetu already mentioned, which is loss of hair, patchy skin, hyper or hypopigmentation, and things like that, Sjogren's syndrome affects a person visibly in many, many ways. The dryness which occurs in the eyes and the mouth causes special problems for women. Especially, I remember that we had a group meeting once, and one of the women wouldn't speak up at all. And I tried a lot to get her to talk to us. And she just refused. A little while later, she came up to me and says, I can't speak in public.
Right.
I said, why? And she says, no, the state of my teeth. Her teeth were so badly decayed that she was ashamed to speak up in a public audience.
Right.
So that's the level of affect, like Neetu mentioned, the body image issue that a person faces.
Correct.
Because as Dr. Latika also mentioned in the beginning, women are affected differently. Women's illnesses are not taken seriously. Dental treatment is very expensive, and a lot of people do not go in for dental treatment. Lots of families do not spend that kind of money. And therefore, a lot of Sjogren's patients do not get their teeth addressed. And teeth is not merely an aesthetic issue. It actually affects the general health of people. So that is one thing. The skin gets extremely dry. In fact, it could be dry to the level of getting leathery. And, there was a time when my skin looked like a pachyderm skin. It was so dry and flaky. And so you have to constantly take care of that. There are, of course, another very peculiar thing in Sjogren syndrome, which is the purpuric rashes. A lot of us face problems due to these rashes. I have particularly a bad case of rashes, and not only my lower limbs, which are totally mottled with the remains of the small capillaries bleeding, but even my hands have become all pigmented because I get my rashes even on my hands. I remember joking with my doctor that I probably walk on my hands because it's supposed to be dependent rashes, but well, I do get them on my hand. So a lot of us suffer from these kind of rashes, which are very visible. And I've had people on the road stop me and ask me, what happened to your hands? So which is very embarrassing to an extent, but yeah, that's what happens. So there are lots of visible effects. Of course, joint pains and all also can happen to a lot of patients, which cause them difficulty in walking and things like that. And I think basically visibly those are the things, but again, we still remain an invisible disease. And lots of people do not even recognize us as being sick. And that has a whole other dimension, which we will discuss eventually.
Right.
Probably Sapan, I would like to add a few more things about body image and what happens.
So, Doctor, we were discussing the visible effects of rheumatic diseases. So we've covered, as you said, as you would be aware, Scleroderma, Sjogren's, and Ankylosing spondylitis. Are there other obvious visible effects that rheumatic diseases have, which you would like to highlight, Dr. Sapan?
Oh, well, apologies for being late. I was held up somewhere, but I don't know what you have probably discussed, but most of the things would have been covered. I think it's actually the things which are not evident, which are more of a trouble. And I tell my patients that, especially my my female patients, that there are two issues. One is the biological issues, and the other are the social issues. And I tell them that the biological issues are the one which we can take care, and we are responsible. And if there is anybody who has any questions, especially if there are young females who are yet to get married and all that stuff. But I said there is a whole lot of social issues which are very difficult to tackle for us. And looking at the sheer number of patients that we have to see per healthcare giver, it becomes very difficult to get into those issues. So such forums would actually be very useful for them. Having said that, I think evident issues the other things are sometimes these patients are anemic, so they are not able to work to the extent that other people can. Obviously, most of them have a level of hemoglobin which would be lower than the rest most of the time because of disease activity. Some of them also have lung involvement. I'm sure Mrs. Neetu must have covered that part, and that makes it difficult to exert. And then as Kirtida said, and that is what we call sometimes when we have these high globulins in the blood and high ESRs, which is called inflammation in our language. One of the clinical markers of inflammation is fatigue. I'm sure Latika would have discussed that, and she specializes in a disease called myositis, which has many other problems. I don't think we are discussing myositis today, but so inflammation is one thing which manifests as fatigue, and sometimes these patients are, since these are things which are not very easily seen, it becomes difficult for the family to agree to it. I think so. These are the main other three things that I would like to say, apart from all that you would have probably discussed. There can be cognitive issues in these patients in the sense that over a period of time, inflammation as well as drugs like steroids, and then drugs can cause a whole lot of problems, which I think is a different chapter in itself.
Chapter, right.
But there are cognitive problems with these patients, so they cannot react so fast to depending on the individual pre-disease, baseline level, and they are bound to happen over a period of time. That is something that which happens to all of us with age. So actually, it's not something that is not seen, but it happens earlier in these patients. So they have to, the family especially has to understand that, all the employers who employ such people. Uh, so I think these are the other things that I'm not sure if they were not covered. So the other things that I could say.
Sure, sure.
Thank you.
Thank you, Dr. Sapan. Dr. Latika, anything that you would like to add that
Yeah,
has been missed
taking
out?
the lead from Dr. Pandya's wonderful summary of broad overview of everything, definitely drugs are another concern at times, and at times I have been in this dilemma what to do, particularly with this medicine called hydroxychloroquine, because patients, particularly in the Indian, colored skin, it can cause remarkable pigmentation, and patients, particularly who are young, they would come up and they say, "Doctor, my skin is turning dark. I don't want to take this medicine," and then like over the past 30 years research has only shown that this medicine is the only thing which is completely indispensable for some of these CTDs. So you really don't know, because for the patient it is the most important thing is pigmentation, but as a doctor, for you it's most important to prevent flares, and at times you just don't know where you stand and what is right. Your entire sense of right or wrong is blurred as a doctor. You just, all you have to say is you have to convince them. And then there
Right.
are diseases like I'm so sorry for whatever Neetu said and whatever she had to go through. And it was beautifully depicted, like all the suffering which scleroderma patients can have. At times, they can have contractures of the skin. And those who have severe arthritis, again, the deformities, particularly in a society where people in the random, trains would ask you what happened to your hands. And these things are fairly common and can have far reaching impact. And not just in young women, like sometimes I had a kid with juvenile dermatomyositis, just a 5-year-old started going to school, and she asked her mother that, "Mother, why do I look so different?" Because she has scars all over her face and pigmentation, depigmentation. And it's very hard to answer those questions for a child who's 5-year-old, that why me? And some diseases have these calcium deposits which will be extruded, like white chalky deposits coming out of the skin in random places. And of course, like the cognitive impact, like Dr. Pandya said, it can be really outsized and unmeasurable. I've had a patient was admitted to our ward last week with a weight loss of 20 kilograms. And we thought that she had some sort of, underlying pathology apart from the disease which she had. And all workup was negative. So she was just depressed because she lost her father recently and she thought that she can't manage alone with the disease and everything else. And another patient just walked in yesterday into the clinic and with that weather-beaten appearance. I've been seeing her for 3 years and I asked her what happened. And it's just family issues and social issues which take you down. So even these can impact people physically and be visible to an astute clinician.
Right. Thank you. Thank you, Dr. Latika. We'll move on quickly to the next topic. I know there's also a question that's come up on lower stomach pain after intercourse, which kind of lends us to our next topic, which is around the urogenital issues as well as sexual health issues faced by women. Kirtida, you want to talk about that first?
Okay. Basically, when we're talking about diseases affecting women, I think these would pop up as the most important things, which is, when we're talking about urogenital issues, they do affect women. And unfortunately, what we are seeing now is that a large number of young people are being diagnosed with, especially Sjogren syndrome, about which I can talk about. We recently did a survey, a patient's survey, and we found that more than 30% patients were in the age bracket of 20 to 30. Right. Earlier, it used to be assumed that Sjogren syndrome affected only women post their prime years, in their menopausal years rather. But now with younger women getting into being diagnosed as Sjogren's patients, I think these problems are multiplied. Right. They not only experience extreme dryness, many patients, not all, but many patients, extreme dryness in the vaginal region. And that causes not only relationship issues, pain during intercourse, and so many other issues. Also, the dryness leads to frequent urinary tract infections. Unfortunately, urinary tract infections often don't get picked up because patients do not complain as often. Now, sometimes it makes me wonder why patients do not complain about their problems at a doctor's clinic. Perhaps it is because there are less number of female rheumatologists, and is that something which prevents women from bringing these intimate issues up at the doctor's clinic? But I would really want to urge patients to please request their doctors to look into these issues, because there are ways in which these issues can be managed and controlled. So my request to all patients is, if you are experiencing any change in your habits, behavior, if you're experiencing any pain or whatever, you must tell your doctor. There are also bladder issues which occur in Sjogren's patients very often. So there is interstitial cystitis, which is a severe form, but there can be lesser problems which need to be addressed early on, so that the infections don't reach up to the kidney and do not cause greater damage to the person. It was very revealing when we found in the study that almost 60% patients complained of having different degrees of genital issues, urogenital issues, and gynecological issues. So it was quite revealing that this number was even greater than those who reported lung and kidney involvement. Right. And usually what gets discussed in a clinic is lung involvement, kidney involvement, heart involvement, major organ saving. All those things get talked about, but these issues get somehow neglected, is what I feel.
Right. Yeah. So it's probably I guess maybe we'll figure out over time whether it's, as you said, whether it's reluctance for people to bring these up in discussions, and we can hear later from Dr. Sapan and Dr. Latika on that. But before that, Neetu, would you want to add as well?
Yes, Aparna, definitely. I would actually like to take Kirtida's discussion further. As she has mentioned, urogenital issues are faced by quite a few female patients, but mostly they choose not to talk about it, because we have been taught since our beginning not to discuss such issues openly. And if any concern is related, especially to sexual organs, it's a taboo to speak about them. Like I know a lot of females who prefer only female gynec, and even then they really hesitate to describe their exact nature of issue. Right. So having said that, the issues which are majorly faced by patients of scleroderma are like tightness and dryness around vagina, like a lot of cuts happening in vagina during intercourse, which can stay for a few days. Right. And during that time, urination is very, very painful for them. And in extreme cases, few of the patients have experienced heavy bleeding during the intercourse. And I remember that one of the females had to get admitted in the hospital to stop that bleeding. And, she was almost like I might die because I don't know what is happening to me. And this is all unheard of. So all these lead to loss of interest by females. They lose interest in sexual activity, which a lot of them have reported. And eventually it creates disharmony in the relationship with the husband, as not everyone is an understanding partner. The most disheartening fact is the majority of them have not talked to their rheumatologist or gynecologist to solve these concerns. And a few of them have tried to talk to the rheumatologist. Their concerns were brushed aside by just saying that yes, dryness happens in almost all rheumatic diseases. So you just need to be a little careful next time and use some lubrication. So I think there is a need of the hour that rheumatologists during appointments, like they generally ask about how they are doing and their dry skin and other issues. They should make patients comfortable and they should start initiating discussions about such issues so that these patients can become comfortable with the doctor and they can talk openly about such issues.
Thanks, Neetu. I think there's a related question, and either Dr. Latika or Dr. Sapan, you can take it. There's one scleroderma patient who's asked if it's normal to have lower stomach pain after intercourse.
Well, I think as pointed out by both Kirtida and Neetu, these are questions which I don't remember have been ever asked to me or ever been addressed to me. Maybe just one or two patients, but there are psychological issues to this and there are somatic issues to this. Psychological issues obviously are there in any chronic disease, and it could be a part of the cognitive problem as well. And it could also be a part of that area of the brain being affected and the organs being affected. And the somatic part of this, some of that you've already discussed regarding dryness and tightness and those issues. And the other things are mainly infections, I think. So that's one thing which these patients are more vulnerable to since they are on immunosuppression. And there might be a host of infections occurring in the urogenital tract of women, sometimes the men harboring these and giving it to the women, those kind of things. So I think that's the other thing which would be more common than, and then there are of course problems like what Kirtida said about interstitial cystitis and part of the disease itself causing issues in the genital tract. There's also the problem of infertility. There is also decreased libido in all chronic inflammatory disease, actually, not just this.
Right.
So I think these are problems, and I really don't know how to address these because it's very difficult to address these in a society which is generally not very receptive to such things. But I'm sure with increasing awareness and with increasing specialities and with the society accepting these things more easily, there is no reason why we can't do it, as Neetu said. And even in our questionnaire surveys, it becomes very difficult to ask these patients. You have to really ask them in when they are alone, kind of thing. And you know how it runs in India. These clinics, multiple people are there, and but you can have a lady medical doctor who can help you. I'm sure that can be done. So these are issues which need to be addressed. I agree there. And I hope that in the future they will be.
Thank you. Dr. Latika, do you want to add to that? There's also one question that should the person has followed up, how do we know if there is infection?
Yeah, I totally agree that this is a very ignored aspect of the disease, although very central to a patient's functioning, quality of life, and even home life and social security and everything else. And I think we get entangled in the societal taboos because it starts at the grassroots level. In general, at school itself, sex education is not imparted in our schools, although that might be changing in recent times. So the problem lies much deeper than we see. And it's not just regarding diseases, but in society level in general. But definitely, this is something which is a responsibility of each rheumatologist to ask. But another problem that we often struggle with is the doctor-patient ratio in our country. So there would be so many patients waiting to meet the doctor, and there'd be limited amount of time that can be allotted. But I feel that this may be set to change, provided we have collaborative clinics with multidisciplinary teams. So if we have a psychologist on board, like Dr. Pandya pointed out, the etiology of any kind of lower pains can be multifactorial. It could be just simple dryness. It could be that you started another medicine. Maybe you had common cold, and that medicine contributed to dryness. It could maybe be resolved in the short term with some kind of lubricant. Maybe you had accentuated pain because of other stressors. So the possibilities are many. And of course, detailed discussion and time and comfort level, all of these are factors which determine if a problem will be solved. So the way forward would be these kind of collaborative clinics. Also, I feel patient support groups have a very important role in comforting and providing this kind of information, because only in the community where you have people who are going through the same suffering or are in the same boat would you find that comfort and feel understood. And there you can identify and learn about certain aspects which would not be so much feasible in the clinic setting. But to that effect, I felt like teleconsultation was a boon in these times, because sometimes these patients, they could really talk to the doctor in the comfort of their homes, and they got the privacy they needed, which they sometimes ironically did not get in the clinic.
Right.
So that is another thing to consider in maybe the future.
Yeah. No, I think a hybrid model of consultation, I think, is definitely a way to go forward. Prachee, I know you brought up in our discussion before this that women with AS, because of the back pain during sex and intercourse, while that's a given, what are the ways around it and how can they handle it?
Yes, absolutely. Because as I said, it deals with the lower back pain. It affects the lower back. Women and the pelvis. Women usually find a normal way of having sex very difficult, and because of the pain, they are put off sex. That need not necessarily mean that they are disinterested in it, but weighing the pros and cons, they prefer not to have it. Again, affecting the relationship between their spouse. So here I would say that we need to address this as a couple concern more than just as a woman's problem. कि तेरा है तू देख ले kinds, no? If they both understand that this is the problem that she's facing, and they kind of try to get creative with the ideas or with positions in such a way so as to minimize pressure on the lower back, or maybe simply use some pillows or cushions or something to give her the kind of support that she needs. That could also, these simple small actions could make a huge difference. Also, one thing that I've noticed is with males and females, but mostly with females, masturbation is a very, very big taboo, and it leads to a lot of guilt. Even that could be one way, say by using various props or other ways, that they can go about satisfying their sexual needs, even as a couple, mutually together as well, than feel guilty or sinful about it. And once we start opening about the concept of sex and not limited to just intercourse, because normally when we think about sex, we only think about it as intercourse. In fact, we at ASWS had a session about it with a psychiatrist as well, so that people can talk openly about it. So if we don't focus about just intercourse and think and read more about how there are various ways you can have a healthy sexual life, I guess that would really open up the interaction and the relationship between the couple, no? And for all you know, with that sexual release, it may actually contribute positively to the illness, and probably they might start feeling better because of that expression, for all you know.
Correct. Thank you. Yeah, so I think it's quite clear that communication between the couple is obviously very important, and we need to figure out improve the communication with the medical practitioners as well, right? So and that probably is going to be a two-way process that we'll have to work on. I think there are a couple of questions around marriage and pregnancy as well, which kind of leads to our next segment. So I think, again, for women in India, two of the foremost socio-cultural issues are marriage and pregnancy, right? I think it kind of comes up in every discussion we have on conditions that affect women. Dr. Sapan, what do you advise patients with rheumatic diseases or their parents or even potential spouses? Because increasingly we hear, kind of even potential spouses going and talking to the doctors to figure out the prognosis of a condition because they don't trust what the family is telling them and so on, right? So, or sometimes patients themselves feel it better to take their potential spouses together and do a joint consult. We see that even in cases of cancer, for instance. Do you advise all patients with rheumatic diseases the same, or do you kind of tend to customize that advice?
You're talking about pregnancy and rheumatologic disease.
Marriage and first
Marriage,
marriage.
yeah.
Yeah.
So, well, as I said, that I tell all my patients, especially who are single, that and it's different for different diseases, obviously, because in a disease like rheumatoid arthritis, you are more concerned about the cosmetic aspects because, I mean, pregnancy does take time in them. Studies have shown, but not much of an issue with them except for the drugs. I need to change. But in disease like lupus and scleroderma, where the pregnancy can actually kill the patient, you have to be more careful. So it is obviously disease-wise. But the general thing is, as I said, that I tell them that there are social issues and biologic issues, and I said biologic issues में कोई problem नहीं है. I normally always end on a positive note. Let me be honest, because I try to ensure. See, the whole purpose, and I believe that of not the whole purpose, but one of the main purposes of women is to mother a child, right? Let's be honest. So the fact that that is very difficult to happen in a country like India unless you get married, it becomes very difficult to sort of convince them. So I tell them that you can call any partner who's ready to come with you and ask any questions. Actually give them an appointment like I do with patients. And I give them 10-15 minutes, whatever they want, for any kind of questions that they have. There is also the email which they can do. There are also SMSs where they can, they can ask questions. Now, to those sort of future partners, I do tell them the truth about the disease, but I try to end on a positive note unless the patient has complications which are, likely to really cause their problems. So I'll be honest there because. And that's how I deal with this problem. But otherwise, with individual diseases, it's you have to advise technically accordingly, and also that they might need to change the drugs as and when they plan conception. So these are
Right.
things that I try and tell them.
Right. Thanks. And Dr. Latika, in most diseases, most cases of RD, rheumatic disease, pregnancy is possible. But do you have any specific? I know you were talking about some of the specific conditions as well in terms of advice for women wanting to get pregnant.
Yeah, definitely. Pregnancy is an issue at times. It depends on the stage of disease, whether it's active, inactive, the drugs you're on, the societal, social structure, the ability to care for the child. But also it depends on the region you are in, because we have seen that in developing countries, the outcomes with the same disease, they may be very different because our environment does affect us. Like we've conducted studies in myositis, we found that women have worse outcomes, the higher abortion rates than in the West. And most of the countries with a lower socioeconomic state or lower GDP, when we compare, in those countries, the outcomes were poorer, suggesting that it's not just the disease, but also the environment is interacting with that dynamic, and it also has some influence. Like in the US, there's more obesity. So diabetes and hypertension were more common. Well, that is not seen in this part of the world. So those are other factors influencing. And there are difficult situations at times when the spouse would come and they would ask for details. And I think patient privacy is something which merits consideration. And I'm sure in Singapore, it's way more stringent. In the UK, a patient, if a doctor is a patient, they cannot even check their own reports. They would be kicked out of the job if they did that. So patient privacy is a huge thing. It's a right which should be upheld at all costs, but some parts of the world, of course, it is heavily compromised, but doctors need to be mindful of that.
Right. And okay, there's a question on whether it's hereditary. Are any rheumatic diseases hereditary? Are all of them hereditary? or some of them hereditary? Either of you, Dr. Sapan, or there's a question specifically on spondyloarthritis.
Yeah, we wouldn't exactly call it hereditary, but the risk is higher than the general population. So we call diseases as hereditary when the risk is very high or there's a direct transfer to the progeny. But here they're heritable, but not entirely hereditary. So the risk maybe would be like 1.5 to 2-fold higher than the general population. But still, the direct transmittable risk is very low.
Right. Thank you. And Neetu, as a counselor to patients in your group, you've had this where kind of families don't want to disclose to the prospective groom or the family. What has been your advice? How do you all handle that as a patient group?
Aparna, it's quite challenging to advise families on this topic. Since the major concerns families have is, agar humne bata diya, to ladki ki shaadi nahi hogi. Which is actually not wrong, thinking, considering the kind of society we live in. But we tell them to speak the truth and discuss the disease, and if possible, make them aware or educate them. I'll tell you, there are various reasons why we tell them. We have a lot of females with us who are emotionally and psychologically tortured by in-laws and husbands since they got to know of the disease after the marriage. So few girls actually hid it. Now, the other reason they would have to take their medicine by hiding from family, and even doctor's appointment would happen when they would visit their parents' house. So this kind of environment where they are not disclosing all the things to family, this creates a lot of stress and pressure on the females, which can really flare up any autoimmune disease.
Right.
So now this gets complex when they choose to get pregnant, because as both the doctors have mentioned, because that decision is now not only in their hands, but it is a joint decision which has to be taken in consultation with the doctor, because the treating doctor will guide and they will taper the medicines or change the medicines, and they would monitor you closely during your pregnancy period. Correct. And all this is not possible if the situation is hidden from your in-laws or husband. And the last scenario which I'm going to talk about is, a lot of female patients, they would completely stop their medicine and they choose not to disclose. But a lot of times after 1 or 2 years, they see flare-ups happening. And now they are in a fix, like whom to consult and what medicines to take. Right. So considering these scenarios, we always tell them it's better to not only talk openly, but ask them to talk to the treating doctor also, like Dr. Pandya suggested, or even we will counsel them. Very interestingly, I would like to share that we have counseled 2 such cases of prospective grooms and family, where the girl was having scleroderma. Right. And I'm glad to see such openness coming in the society. It might be a small change right now, but every small drop counts. And if our intervention can help a girl getting married with an understanding family, why not? Right. So that has been my experience and my thoughts.
Right. Any other points, Kirtida, that you would want to add to this? Unmute, please.
Sorry. Another thing which happens in case of Sjogren's patients is that a pregnancy can sometimes result in problems for the child. And that, I think, is very, very important for both parents to be aware of. So this hiding business will really ruin the outcome of the pregnancy in case there is a problem with the child having congenital heart block. Maybe Dr. Sapan can throw greater light on that issue, especially because it happens for Sjogren's patients.
So the anti-Ro antibody, which crosses the placenta, and in the first time it's only about 2% actually, and then it increases to about 18% the next time if you had it once. So those are the figures we quote, which have come from some study which has been done earlier. And then with the increasing pregnancy losses, the chances become more. But otherwise, what one needs to know that the first time the chance is only 2%. So you need to control the disease, has to be in control, whether it's Sjogren's or lupus or any disease. The inflammation has to be under control when they plan conception. The drugs have to be such that they don't cause problems. And then you have to monitor the fetal heart sound of these children, of these pregnancies, right from 16 to 18 weeks to about 24, 28 weeks. And then depending on what kind of heart block they get, if they do get, we try and infuse them with some kind of steroids and other drugs. But sometimes even after doing that, these babies have issues when they are born. So these are things we share with the patients. I'm not sure how much they actually understand the percentages. As healthcare givers, it is very easy for us to give them percentages. But
Correct.
and then we give percentages. But for that patient, it is 100% if she gets it. So you
Correct.
have to remember that when we say so.
Yeah.
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 So would
And
it,
sorry,
can,
go ahead.
can I just ask one
Sure.
question to the doctors,
Sure.
which is, would it be advisable for people to consult the doctor before they decide to go in for pregnancy if it's
Yeah,
not
I
an
always tell them. I
active?
always tell them, and I'm sure that's what is done at SGPGI too. That you need to tell us when you want to plan your pregnancy. The young couples, we always tell them, because you'll also have to change the drugs accordingly. And in Sjogren's, yes, you have to educate them beforehand, and we need to know.
And you need to tell them for, kind of, you plan 6 months ahead, 9 months ahead, what's that
Yeah,
period?
that's the best. The disease generally has to be in remission for 6 months, and then it's okay. Even for rheumatoid, actually, it is the
Right.
inflammation and the active disease which actually causes problems rather than the rest of the things. So it has to be
Right.
under control.
And do rheumatologists typically work in conjunction with the gynae as well? Because sometimes we've had a couple of people commenting both on the
Yeah,
YouTube
I,
as well
I, I
as
read
here
that
that
comment, and I think that's
gynaes
very
are
true.
unaware of
Yeah,
autoimmune
that's
conditions.
very true. I'm sure Latika will agree that we've been telling since almost time immemorial that don't stop hydroxychloroquine in these patients, and that's a problem I think in every part of this country, especially for lupus patients. That somehow the gynaes tend to stop that, and we tell them don't do it, please, because it's one of the most useful drugs for lupus patients. But yes, I have lately, and I must admit that lately, started taking the numbers of these gynaes from our patients so that I can directly talk to them and tell them, "Ke bhaiya aisa mat karna," and that most times once you talk to them, they are confident. So you are right.
Right.
I understand what you're trying to say, that we should be, and what Latika also said, joint clinics and those kind of things. In a private setup, that becomes a little difficult, but we can at least talk to them certainly. So that helps. They once you tell them, they don't do it. So then they are
Correct.
confident. Yeah.
Correct. Because it's very difficult. I mean, otherwise you would tell the patient don't stop at CQS, and then the patient can't tell the gynae,
That's what happens.
so
So it makes
yeah.
sense to talk to them and work in
Right.
conjunction. Yes.
Great. Thanks. Um, if we go to Prachee, let's talk of some of the other social issues. I think it was talked about earlier as well by Dr. Latika and a few others. Fatigue is one of the most misunderstood issues, right, in a sense of dealing with a lot of chronic conditions, including AS. How does this affect women on a day-to-day basis, especially in, again, a country like India where women are supposed to kind of be responsible for all social interactions, in a sense?
See, we need to understand one thing, the caregivers also need to understand one thing, that our body is battling the illness every day, visible or not, it's still battling inside. And for years, and it's been battling for years, and as Dr. Sapan Pandya rightly pointed out, that there are cognitive issues. Because of the chronic fatigue, we start getting brain fog. We kind of forget even small things, even basic day-to-day stuff. Even a simple thing like planning the day out is tiring enough. If I want to attend a function, just getting ready for the function tires me so much that attending the function is a bigger task
Hmm.
than what it is for normal people. Usually, being tired is our default state. We don't wake up fresh. We are
Right.
default tired. Even rest doesn't help much. We are always, the spectrum for us is fatigue, tired to extremely tired. It is never in the positive side. And that kind of takes a toll because people don't realize that. Even as I said, that because of the brain fog, doing simple tasks starts getting difficult for us. And gradually we start learning that we need to choose our battles, we need to prioritize things. And if we have something to attend, we learn to take those things slowly. Days before we try to go slow with the things. Then on that day we kind of attend and we put on a brave face. And then again we rest for 3-4 days. But however, this is what our body needs, and this is how we've tried kind of planned ourselves out. But when if we are with some people around us, some caregivers who are not sensitive enough, how they see it is फंक्शन में तो अच्छी थी, सबके सामने तो अच्छी थी, बट बस घर के काम करने में इसको प्रॉब्लम होता है. पहले फंक्शन के पहले उसको आराम करना है, फंक्शन के बाद आराम करना है, बट लोगों के सामने बहुत अच्छे से रहना है. दैट सो दे क्लासिफाई दैट एज नाटक कि नहीं ये तो नाटक है ना, सबके सामने कैसे सब सही होता है, घर में ये आलसी है, एज आई सेड अगेन, ऐसे काम नहीं करना चाहती है. However, they don't realize that this is the choice that we are making. Again, if we choose that no, we don't want to attend that function. If that is the case, we'd rather go on with the regular life. उसमें भी people will have a problem कि नहीं, she's just trying to show off कि बाबा नहीं ना बीमार हूँ करके. So it's not that we don't enjoy socializing. We enjoy social, but we no longer have that bandwidth to do the same. It's not that we don't want people to come home. It's not that we don't want to carry out with our responsibilities like as Dr. Sapan said, pre-disease situation. But currently we are not in that bandwidth. Again, brain fog and fatigue plays a very important role because of the brain fog, just thinking कि लोग आने वाले हैं, that itself tires you out. No? So if the close family members need to understand that this is an ongoing struggle and they need to make it more comfortable for us, understand that we are not faking it. We may put on a brave front, but if we are faking it, we are faking being good, we are faking being well, we are not faking being ill. So if they try to understand that it will help us to strike the right balance between our health, between our duties, between our enjoyment as well. So I guess that is one thing that the family needs to support and understand.
What would you tell women going through that fatigue? That's the advice to the family, but what is your advice to the women?
Yeah. To the women, I would say absolutely listen to your body, because your body is screaming and telling you things. You're already, and as I said, many women go through that guilt of paying because they are already spending money on themselves. They're already giving themselves time visiting doctors, and so they go through that guilt of not giving themselves more time. Or not giving the family more time, rather if they give more time to themselves, so they need to understand that that is not what it is. They need to give time to themselves and they need to focus on themselves. If the body is fatigued, resting is not being selfish, it is being self responsible. So if they kind of rest it out, if they listen to the body, if they take it at their own pace that they are comfortable with, eventually that will also in turn affect their interaction and their quality time with the family. It's not just the quantity that matters. If they start taking care of themselves, if they start listening to their fatigue, and again choose your battles. I mean, you don't have to be all present everywhere. Choose which things are important, which you need to attend, which you don't need to attend, which socializations you can let go. So if they start making those choices and start respecting and start letting go, that would really make a difference to their overall interaction.
Okay, thanks, Prachee. Neetu, do you want to add anything else in terms of the level of support women get from families or don't get, or the challenges they face?
Yes, Aparna, I have a couple of things to mention over here. I will just take few threads from Prachee's thoughts. So let's understand the basic nature of these rheumatic diseases. The keyword here is unpredictability. So with this in mind, it's quite challenging to get the kind of support we all need from families, because they would not understand what we go through on a daily basis. And we have had a mixed kind of response from our patients group. Unfortunately, we have young girls who have talked about being ignored by their parents and their siblings even. And they are treated not more than a responsibility. And their value addition to the family, in whatever small form it happens, is not appreciated, and they are not taken into consideration while making important family decisions. Because वो तो सिर्फ एक responsibility है जो माँ बाप को पूरी करनी है. That's it. Because in their minds, शादी तो शायद इनकी होगी नहीं. No? Right. So the biggest chunk of problem comes from teenager kids. They face another set of issues for females, as the females are not active much and not presentable most of the time, because we like to be in our comfortable clothes. The kids start resenting their mothers as they see other mothers getting dressed up nicely and maintained well and taking care of all the activities of their kids, which obviously a rheumatic patient is difficult to maintain that standard of care for the kids. Another important fact is families where finance is an issue. They openly blame the female for the expenses being incurred on them. Yeah. As we all know, all rheumatic diseases are a costly affair, and this leads to stress, depression, and self-worth issues. Right. And I'm sure everybody would understand on this forum that almost 70-80% of females are being diagnosed with depression, with autoimmune issues. Now, very interestingly, all the issues are being faced by females, either from their husbands, in-laws, kids, or even parents' side. Now, the male patients have never faced any such issues, since culturally, the females have been conditioned to support their husbands come what may. So these are my thoughts actually on the support which female get from their family.
Thank you. Thank you. I think we could probably go on, and I know that we have kind of passed our time, but let's move to the last segment, which is really on the patient-doctor interaction. I think we often find that, and we've talked of how women are not able to express their issues or concerns, but also sometimes they are not taken seriously enough, or the concerns are dismissed, or sometimes they are told, okay, at least it's not as difficult a disease as cancer and things like that, right? So one of the things that patients sometimes tell us is that if the doctor does not take it seriously, then how will my family take it seriously enough, right? So how can we change this, the style of communication that doctors have and towards patients, and what can we do together as patient leaders and doctors to change this scenario? Dr. Latika, Dr. Sapan?
Yeah, so I think this is a problem which is indeed very much present, and patients have to bear the brunt of it, because poor communication, poor awareness, it translates into poor outcomes directly and a poor quality of life for the patient. So the only solution is good communication. And not only is it diligence in communication, there has to be warmth, there has to be the right balance of information, which can be very different for every patient. And you need to give them that quantum of time to settle in and to understand their deep-rooted problems, because a patient may say that, oh, I'm just not eating well. And then when you go on asking them, how much do you sleep? What time do you sleep? What time do you wake up? Invariably, I find out that there's something wrong with the sleep-wake cycle. And then we get to know what are their personal issues, what are the problems at home. It is actually some sort of stress, crystallizing into those symptoms. And as I said, we doctors also struggle with the doctor-patient ratios, the setting which we practice in. Like Dr. Pandya said, sometimes there'll be 3 patients standing over your head. So it totally depends on where you are practicing. If you today I'm in a camp, then the situation may be very different. So we need a very multi-pronged approach to tackle this kind of problems. Like Prachee said, the disease is not understood, fatigue is not understood. Yes, in fact, this is a very common problem worldwide. So spondyloarthritis, there's a median delay of 10 years in diagnosis and even more in women. So because the symptoms are so non-specific. It's a problem worldwide. Those who get diagnosed are lucky enough to at least have a diagnosis. There's so many people walking around who just don't know what they have. And with Neetu, I think it's truly commendable the kind of work you're doing, convincing families and making them aware of the diagnosis, the implications. But I've had patients where a patient was disowned by her family. She's a patient of MCTD, her sister has Sjogren's, thrown out of the family because she was not ready to hide her illness from the prospective spouse, and ended up not being married. 20 years down the line, the disease has not caused so much pain as separation from her mother and village and family has. So there have been very painful stories, and it's truly difficult. Even mother and child relationship can get affected, as Neetu said. We recently published an interview with an Australian myositis patient who's a psychologist herself. And the pain was unbearable because her children started to try and live a life without her. Just because they could see it, that our mom is not going to be around in a few years' time, although that never happened really. But like any kind of grief and suffering, it can have far-reaching implications and different reactions. Every human may interact differently, and every member of the family may interact differently. So sometimes you'll need combined sessions, sometimes you need individual sessions. So I do feel like most doctors would need counselors and collaborative practice, and patient support groups can really take the lead in doing a lot, because some problems are better understood by patients than doctors ever will, because they have not gone through it themselves.
Right. Dr. Sapan?
Yeah, I think, it's what Neetu said is, I think I'll agree to her, and what Latika said also. Not just one patient, but hundreds of patients. There are so many stories and so many touching stories. I've actually started writing them up as soon as I leave my clinic on that very day, and I've shared without the name with some of my friends. I like to write some very touching stories, and as Neetu said, it's mostly, or perhaps always, females, and somehow the males in our society, as she said, don't have that much of a problem, if none at all. I don't remember very many male stories certainly, but most times, having said that, I think it's just remarkable the amount of work that Indian women, I'm sure women all over the world, but the Indian women can do, especially the rural folk with all these diseases. It is just amazing the amount of work with the deformed hands that they do, and there are so many touching stories, as I said. But having said that, coming to your question, I think I would like to say 5 things about this. The first is that there are some things we take for granted in our country, and for example, only when you go abroad and you talk to people, I'm just giving an example, you realize that they don't interrupt you when you're talking, and we do that all the time here, and we don't even realize that we do it. So that's just an example. So there are so many things that those sex biases in our mind, even as a doctor, that I have to see those things to realize that I myself am doing it. So that's number one, that as doctors we need to understand things which are just a reflex in our country, number one. Going from there, the second thing is, as Latika said, talking to the families and patients, we do try and communicate to them, and it just takes a little while. I think when you are younger and you don't have time, and you have too many rabbits to chase, and you don't know how to chase those rabbits, as you grow older, you realize you become more empathic, you also become better in your temperament, and you have gone through, you've heard a lot of stories, generally should make you more sensitive. And so we have to talk to the families sometimes and try to tell them that, what I tell them is ke 100% तो नहीं होगा, लेकिन आप at least 80-90% तक पहुंच जाओ, ये हमारा idea रहेगा. I mean, you cannot go to the pre-disease level back, because that's going to be very difficult, let's be honest.
Correct.
But at least, and as a husband or as a family, you need to understand, don't have wrong expectations from your, and you try and tell them, you mix a bit of wit and humor, because you have to do that in India, and only then it works. Only recently, I'll give an example. I had a rural lady coming to me. She's been coming since quite some time, Scleroderma patient, and she tells me that I have to wake up at 5:30 and start things. I said, why? So he said, this fellow tells me to wake. Yeah, they were a good, nice young couple and got along very well. So I said, why do you force her to get up at 5:30? He says, no, it's all right. I mean, she can get up late also. So I said, then make sure. The next time she comes, she says, now I'm waking up at 7, I'm much better. Simple thing, as Latika said. I just talked to the husband. He was a nice guy actually, but he just didn't know. I said, better just do this. So things like that. And the third thing is, as again Latika said, support groups are extremely important. That I'm probably aware that in our country, patients listen to the doctors sometimes things as the final word rather than the patients. But in societies which are aware, I think patient support groups can help, and there are some things which only you will know that we'll never, as Latika said. But you can tell us, and then we can tell them, kind of thing. So they listen to us more easily. And then most important two studies, the last two things. One is that we really need to study these issues in a proper way. What are the and we need to really come out with hardcore data to tell the society, for example, what Latika did in her studies, or which we've been thinking of, and Kirtida has finally done a study, I think, which we saw. Only then in society will listen to you. We need to get those published and tell people this is what is happening in our country, and we need to really work on it. So studies have to be done, and I think simple questionnaire based studies are something that you all can very easily do, since we make an excuse that we don't have that much of time. We might be having, but that's an excuse we always doctors give. And the last and the singly most important thing, and I've been thinking about since quite some time, is we have to make the women financially independent. That is the only way out. And so I have these very young, and I'm sure Latika also has, SGPGI also has these young women lupus patients who are so well educated, and they don't have a job. So as a fraternity, as an association, the Indian Rheumatology Association, or as a rheumatologist in Ahmedabad, or we also have state chapters, and then we have support groups like you. We need to ensure that these women are employed somewhere, and I think we can have a way out, and that they are financially independent. I think that it's a big thing to be financially independent. And even if they are not educated, with whatever level of education they have, as a society, I think that's our responsibility. And once we do that, things, I think, will be much better. That's simply the singly most important thing I feel. So these are the 5 things that I have to say. Thank you.
Thank you. I think very succinctly put together. I just have one comment, Dr. Sapan. Actually, the US studied this. I think it's Dr. Victor Montori quotes this. That in the US, they found that the doctor interrupted within 11 seconds of the patient talking. And I wonder what it is in India if it's 11
I'm talking
seconds.
about normal conversations, not even doctor-patient.
Yeah, I think they did the study of the doctor-patient and said it was 11 seconds, and I don't know what it is in India.
Generally, India, we doctors think we are emperors, so we can interrupt anytime. But I'm talking about general conversations also.
Yeah.
We interrupt so easily.
Correct.
Just as I did just now.
Yeah, and the one question I had was, I know we talked of the psychological impact, and while traditionally counseling was not kind of considered as part of the supportive treatment options, are you now kind of actively suggesting patients to see counselors now, since it's getting to be slightly more acceptable? Either of you?
Yeah, some of them, not all of them, because many of the times we have to play all the roles, singly. So also because most of them can't afford those kind of things.
Right.
You're only talking about that particular proportion of patients who can. Yes, we do tell them, and they have started accepting it. So we are doing that now, but not to the level that you see elsewhere.
Sure. Thanks. And as patient leaders and counselors, I think this is the final question to you as well, all of you. We find that patients talk to multiple people. They still do not understand that the management of these conditions is an ongoing exercise. We do recognize that there is an issue on the patient side. Some of them want quick fixes. They keep switching protocols, etc. How can we all work together to help them understand better? And I'll go around to each of you on this. Prachee?
Yeah, that is true. People go to various people because usually when we think about an illness, we presume that it should be short-lived. It's not ongoing. बस सर्दी खांसी हो गई, बुखार आ गया, कुछ हो गया, दवाई दिए, खत्म हो गया. Then when they realize that this is ongoing, it's not. And as Neetu rightly pointed out, there are good days and bad days. varies every time. So if when there are good days, they believe कि ठीक हो गए हैं, and then suddenly they think they can stop medications, and then वापस वो there are bad days, and then they feel that this medicine is not effective. Then they try other things. There are people telling them कि अरे इतने पेन किलर्स लोगे तो खराब हो जाओगे, ऐसे कैसे डॉक्टर ने प्रिस्क्राइब किया. So because pain killers, especially with AS, it's kind of needed every day most of the time. So they again start switching, and then you have fake doctors who kind of assure many things. So people go through those struggles. What I think is the key is the doctors, the rheumatologists especially, because I know that people are going to go around the world and then again think that they need to go back to the rheumatologist because kuch asar nahi hua. So when the patient goes back to the rheumatologist, the if the rheumatologist has that, instead of like a teacher approach कि अरे क्यों किया ये सब, if they are like more welcoming and more ये क्या हमें तो पता था कि तुम जाकर आना है, finally यही आने वाले हो, if they're more welcoming and more supportive of the patients, I guess patients will be more open and more comfortable to go back. नहीं तो it's the fear कि गाली पड़ेगी, डांट पड़ेगी करके they fear going back to the rheumatologist. And with that, again, as I earlier said, if we make them realize the importance of giving those 20 minutes, half an hour, 1 hour to themselves every day, doing their exercises or giving themselves that relaxation time than being stressed about the duties the whole day, and making them realize that once they invest in themselves, they are actually investing in their family. I guess that would also bring about, yeah, and they need to realize that even the family deserves a better you. If they realize that the family deserves that, maybe that would help them keep it ongoing so that they don't go off track again.
Right. Thanks, Prachee. Kirtida?
I really want to talk about one of the questions which comes up all the time with patient leaders. It is, please recommend the best doctor. That is what I get asked every time. And I really hope that a very small analogy will explain what is a best doctor. I think basically long-term communication and a long-term relationship with your doctor is very, very important. Look at it as something like when you get your clothes tailored. You cannot buy something from the market because everything doesn't fit you, or it's one size doesn't fit all. So you have to go to a particular tailor. You have to get your disease addressed with your particular needs. The medication has to be tailored to address your problems. Just like when the first time you encounter a new tailor, you may not get the perfect fit. You don't throw away your clothes. You go back to him. You make him do the changes that you need. So that's what you need to do. You have to build a relationship with your doctor. You have to go back, get your medication altered if there are side effects, if there is something else that needs to be added. But if you just stop your medication, or if you just walk out of that relationship and go scouting for the next good doctor, then usually there are problems. Also, your size may change, your needs may change. So that time you need new medication, you need changes in the medication. So it's very important to follow up. You can't just end at having the same measurement and going and buying the same clothes because they no longer fit you. So I would really like to urge all patients to have the patience to build a relationship with their doctors. Similarly, the doctors can be a little more patient with the patients and allow them the benefit of making mistakes, learning how to communicate with them. As a patient leader, I always try and explain to patients that they need to respect the doctor's time, and therefore they have to be very organized when they go to a doctor. They need to have the questions ready, they need to have all their reports ready, and they must try not to waste the doctor's time. Similarly, the doctor also needs to reciprocate, and I think only working together will solve these issues. Also in diseases like rheumatic diseases, one needs a multiple specialist group to address all the various needs that a patient has. But more important, and something which doesn't get often recognized, is the importance of a general physician. And I would say that having a general physician for each patient is very, very important, because when you get malaria, when you get a stomach infection, when you get something else, you cannot expect the rheumatologist to have the time to attend to that. Your physician, who is aware of your disease, needs to take care of all these small ailments. He or she needs to take care of the vaccinations and whatever protections you need and things like that. So everybody, please cultivate a good general physician as my recommendation to patients.
Thank you. Thank you, Kirtida. Yeah, I think what we really do need to figure out in India is a robust referral system. I think that's one of the challenges we have still. Neetu?
So most of the things have been covered by Kirtida and Prachee. So I will just try to touch upon the magic pill which you mentioned. So it's a fact that almost all patients are looking for shortcuts to get better. And management of disease is a non-existent concept for most of them. So we try to introduce this concept by counseling them and their families if required. So there are few important things which I would really like to say, that there are 4 important pillars for every autoimmune rheumatic disease. The first and most important thing is to make them understand there is no magic pill that can give you relief, like as a simple Dolo does. The medicines take time to show results, and sometimes few medicines can take up to 3 to 6 months to show any considerable results. Because as Kirtida was mentioning about doctors, a lot of patients come back that हम तो 2 हफ्ते से दवाई खा रहे हैं मैडम, लेकिन अभी तक तो कुछ नहीं हुआ, तो अब हमें कोई नया डॉक्टर बताइए, हम किसी और अच्छे डॉक्टर के पास जाना चाहते हैं. So the other important thing is the journey does not stop once you had your doctor's appointment and you start popping pills. In fact, that's the start of the journey, and hard work needs to be done in terms of 4 important pillars of the disease. Making sure that you take your medicines on time, don't skip them, do some exercises on a daily basis. And if you are in severe pain and not able to do any physical activity, please consult a physiotherapist. Then third point is you need to eat good food. So this is something, which needs to be discussed on patient-to-patient basis. And the last and the foremost thing, which even Dr. Pandya has talked about a lot today, is maintaining good mental health. So I believe these are the 4 pillars. And if all patients start believing in them, they would really see a drastic change in their condition.
Right. Okay. Thanks. I think we are the 90-minute mark. Dr. Sapan and Dr. Latika, any final words before we wind up? I think we've covered a lot of ground.
It was an excellent forum, and I think we had we have participants, right?
There's about I think there were about 30 here, and then there's a few on the live stream as well.
So I think as we concluded, both of us we together need to work on these issues, and I hope that our patients will have a good quality of life. We're already reaching good levels of survival in these diseases, which was not there before. But now what matters after you have taken care of survival is the quality of life. So with the current tools available and the rheumatologist patient ratio improving in India, I see no reason why we can pick up these diseases early and educate our patients, where your role will come, because you can certainly help and the patient support groups can certainly help there. And see to it that patients live near normal quality of life. That's my final message. Thank you.
Thanks, Dr. Sapan. Dr. Latika?
Yeah, I totally agree. I think societal perspective needs to change, and it will in the years to come, thanks to all these lovely patient support groups. Maybe 20 years ago or 50 years ago, if someone had diabetes, it was like a death sentence. But today, that stigma is not there. And even with rheumatoid arthritis and some of those rheumatic disorders, we are moving towards identification of early rheumatoid and even pre-rheumatoid now. So hopefully in the next 10 years, we will get there where we can identify the disease before it sets in. Even in systemic sclerosis, there is stem cell transplant, newer therapies are coming in each day. We recently had a new medicine which is working across most rheumatic diseases. So societal perspective is set to change with more awareness. People will no more stigmatize, and this will go a long way in improving quality of life for our patients.
Thank you. Thank you. So I think with that, we will wind up. Thank you to all our panelists and our viewers. It's been an incredible session. I think there's a lot of takeaways from this one. It's been extremely insightful. Clearly, we all need to work together to support patients in their journey towards better quality of life, and patients and families need to work to make sure that they learn as much about their disease and learn to manage it, as well as and the learning to manage is not just from doctors but also other patients who can share through these support groups as well. And kind of feel more confident, because I think, as Dr. Sapan and Dr. Latika both said, that there are new treatment options available. The survival rates of these conditions is not just survival rates, but I think there's a lot more in terms of quality of life that is possible now. So it is possible to live near normal lives. So I think we need to all work together to make sure that we do our best in this, to make sure that happen. So thank you once again. And thank you also to our attendees who are following this on various channels.
Thank you.
Thank you, and bye-bye.
Thank you.